Perfect. So let's get started. I'd like to introduce Natalie. Natalie Leon is a nurse clinician, sorry, who has been an active and working member of the Jewish General Hospital community for nearly 20 years. Nowadays, she's a nurse navigator, also known as an infirmière pivot for the colorectal cancer division. In this role, she continues to work closely with her medical partners to help patients understand their personalized care plan while providing symptom management, and psychosocial support throughout the cancer care trajectory. Natalie, on behalf of Hope and Cope, I sincerely thank you for generously offering your time to come and speak with all of us here today. We are very grateful. So without further ado, Natalie, I yield the virtual microphone over to you.
Thank you very, very much. On this gloomy Thursday morning, I thank you all for taking the time to come and listen to this overview of colorectal cancer. Many of you, I can see in the chats and the names, are some of my patients. You can validate for the information that I will be sharing amongst everybody, and it's nice that you all have taken the time to listen to what I have to say. So this is the first time that I'm ever doing something like this. So I asked for some patience and some guidance as I'm a little bit nervous, but I hope the information is comprehensive and easy to understand. I tried to deliver it in a way that it's user-friendly and that it's at a level that the information can be, the word I'm looking for is understood, that when you take this information after this talk, you can bring it back feeling empowered, confident, and actually understand to have those clinical discussions with your medical team. So this webinar was designed to increase your knowledge and understanding of what colorectal cancer is. My hope is that after review of the educational material, you'll have an awareness and feel more confident to be an active participant in your decision-making for your clinical treatment plan. The role of an IPO nurse, or an infirmière pivot, or as Annie said, a nurse navigator, like myself, is to help someone make informed decisions as they navigate through a very complicated and at times emotional cancer trajectory. I want to provide you with a sense of control during a time of uncertainty with some of the things you can control in your treatment plan, designed by a very comprehensive multidisciplinary team. So without further ado, the title of my project is Colorectal Cancer Decoded and Understanding into Your Diagnosis. After I finished the presentation, I looked at the title and I said, that's a mouthful and it probably should be very simplified, which is a patient journey overview of what colorectal cancer is. So give me a second. Here we go. So here's a brief summary of the agenda for today. We'll talk about the anatomy, the incidence and demographics, risk factors of colorectal cancer, signs and symptoms, screening and diagnostic workup, and treatments that are available for colorectal cancer. Today is the last day of March, so we got it in at the very last minute. This whole month of March was actually Colorectal Cancer Awareness Month. A lot of community activities have been going on to showcase the importance of colorectal cancer, the prevention, the screening, clinical trials, and treatment options that are available for patients. So I'm happy that on the last day of the month, I was able to put this presentation together. No conflicts of interest to disclose at this time. So let's start off, and let's start off with the anatomy. The colon, as you can see from this picture, it's a tube-like organ, and it's approximately 1.5 meters or 5 feet long. Colorectal cancer originates from the epithelial tissue of the colon, and it may develop either on the right side of the colon or on the left side of the colon. Depending on the position, colorectal cancers behave differently in terms of disease progression or in terms of overall survival rate. The difference between these tumors can be attributed to the origin, anatomically, where it's located, and distinct factors such as biomarkers and the bacterial population of your colon. We'll go into more detail as we go on throughout the presentation, but I wanted you to see what exactly does the colon look like. So here again is another representation of the colon. What does the colon do? So the colon has key functions: absorption of water, nutrients, electrolytes, the forming and the propelling of your feces through the colon. The colon's entry point is here, right here at the cecum, and then it's divided into segments. So we have the ascending colon traveling upwards, the transverse colon traveling across, the descending colon to terminate with the sigmoid colon and the rectum. What's important to note is women, the right side, what's important to note is patients with right-sided colon tend to be more so over the female population, whereas left-sided colon cancer tend to be increased volume of men. The prognosis tends to be, from research, overall worse when it's a right-sided colon cancer versus a better prognosis when it is on the left side. So what is colon cancer? Colon cancer is a disease of the colon or the rectum, which are the parts of the digestive system. Cells in the colon or the rectum sometimes change and no longer grow or behave as normally. These changes may lead to non-cancerous tumors, such as inflammatory polyps or hyperplastic polyps. The changes of the cells of the colon and the rectum can cause precancerous conditions. What does that mean? It means that abnormal cells that are not yet cancer, but they can develop into cancer if not treated. The most common precancerous conditions of the colon and the rectum are, we'll speaking about them, hereditary colorectal syndromes and adenomas. Most colorectal cancer cases occur in patients ages 50 or older, but there has been an increase in the younger population. So as you can see from this diagram, normal cells that multiply, and then the final is a malignant cancer cell. This is the pathway of what colorectal cancer would look like. Incidence and demographics in Canada. Did you know that colorectal cancer is the second most common cause of cancer death in Canada? Yet, if caught early enough, 90% of cases are successfully treated. This is why I cannot stress more and more how important prevention and screening regarding colorectal cancer is. Again, most cases occur at ages 50 and older. We have been noticing an increase in the younger population, and screening methods tend to only start later in life. So unfortunately, with the younger population, sometimes the diagnosis hasn't caught early enough because physicians, i.e. a family doctor, is not thinking that this might be a representation. The signs and symptoms that patients are describing may be an indication that a cancer is brewing. So colorectal cancer, again, in Canada, these are the incidences where we're at. 1 in 14 men will develop colorectal cancer in a lifetime. Where in comparison to women, it would be 1 in 18. 93% of the colorectal cancer cases are in adults over age 50. But again, this has been an uptake with the younger population. There are risk factors. We'll be discussing those that are important to note. Some of these risk factors are out of our control. They're just part of your genetic background. And some of these risk factors are modifiable and you have control, and we can therefore decrease the incidence of cases that we see. Again, screening and detection, very important. 65% of Canadians diagnosed with colorectal cancer survive 5 years or more. The average lifetime risk for men is 1 in 14, as I mentioned, and the median age for men to develop colorectal cancer is 66 in comparison to women at age 69. The rates tend to seem, we're starting to see a trend in the literature of declining rates among men and women. Why are they declining? Is it because we've now been highlighting the importance of screening? Is it related to different types of treatment and clinical trials that are available that are decreasing the rate of the colorectal cancer cases? Many driving forces are affecting these numbers that we're seeing, but there's nothing yet concrete as to why. In 2021, 24,800 Canadians were estimated to be diagnosed with colorectal cancer. And these are statistics that were pulled from Public Health Agency of Canada. Also, again, in 2021, 9,600 Canadians, they believed, according to stats, we believed would die from colorectal cancer. Risk factors. So as I mentioned before, risk factors, there's some that we can control and some that we can't control. For the ones that we cannot control, our age, our genetic makeup, our personal history, these are things and factors out of our control. Some of things that we can control, which are modifiable, is smoking, our alcohol consumption, our sedentary lifestyle, our diet, trying to decrease the amount of processed foods that we eat, exercising more frequently, and incorporating that into our lifestyle habits. These are things that account for where colorectal cancer has, I think, is seeing the fluctuation in trends of the modifiable factors. We are starting now as a society to promote healthy eating, exercising daily, and maybe those changes that we're making are starting to now materialize as changes within the incidence of these cases that we're seeing. Inherited cancer syndromes. So what that is, it's one of the risk factors that I mentioned, which is unmodified. That's your family history. When you look at whether or not you have a close blood relative who's had colorectal cancer, one or more, that might be a factor as to what your path will be. Sometimes it's not clear whether the family pattern of cancer is due to a shared lifestyle. We all are sedentary, we all eat processed foods, or is it due to a genetic makeup that's being passed down from parent to child? I've highlighted here in this slide 2 inherited cancer syndromes that I think require mentioning because there's a lot of attention placed on them. The first one would be FAP, familial adenomatous polyposis, which is a rare inherited condition. It's usually in about, I would say, 1 to 5% of the population. And what it is you will find it's a mutation in the APC gene. That mutation causes hundreds to thousands of adenomous polyps to develop in the inner mucosa of the colon and of the rectum. As you can see here on the picture, this is a healthy colon, and here's one with lots of polyps that are developed. Lynch syndrome, also known as HNPCC, is another inherited condition caused by mutations in the gene that correct mistakes when cells divide and DNA is copied. It causes polyps also to develop in the lining of the colon, but not as many in comparison to FAP. Signs and symptoms of colorectal cancer. Typically, what we've seen is early stages of colorectal cancer have no signs or symptoms. Therefore, colorectal cancer is known as a slow-growing cancer. because more often, we do not know that we have this cancer until we have overt signs that develop. What are those signs? Bleeding from the rectum, blood in your stool that is visible that you can see, changes in your bowel habits that are marked changes. So for example, if I was a patient who had a bowel movement every morning after breakfast, and all of a sudden I'm not having a bowel movement after breakfast, I'm struggling to have one, and sometimes I'm constipated for 2 days and require additional natural supplements in order to have one, that's a marked change in what your normal baseline is. An abdominal mass that maybe the patient themselves can feel, abdominal cramps, pain that are persistent. Sometimes patients have told me, oh, I felt like I was just having gas all the time, or it felt like there was always a cramp after I ate, but I just dismissed it to having a heavy meal or skipping a meal. Another hallmark sign or symptom is unexplained weight loss. You have a sudden loss of your weight, even though you're not doing any dietary changes. What's interesting about this is all of these signs and symptoms that I've described here are actually easily explained away. Many times, patients do not seek appropriate medical follow-up when these symptoms come about because, for example, the bleeding in the rectum, patients will chalk it up to, oh, I might just have hemorrhoids. And I was forcing that day and maybe I disturbed my hemorrhoids, so that's the blood. What I want to partake and share is that it's important that if any of these symptoms evolve, come about, present, you need to seek medical attention. If you have a family doctor, schedule a follow-up because you require some more investigation to see what's happening. Lifestyle changes can reduce the risk. So exercising, drinking in moderation, of any of these risk factors, any of these symptoms occurring. But what's important is, should these signs or symptoms present, seek medical attention to see and explore what else is going on. Seeking medical attention, screening and diagnostic workup. What does that look like? So here's an example. I have a patient, 28 years old, said I had rectal bleeding. I thought it was hemorrhoids. I'm knowing to have hemorrhoids, but I didn't do anything about it. What could have been done about it, she says? Well, once she had that feeling, she could have actually had a follow-up with her family doctor. The family doctor at that point may prescribe one of the 3 tests that are written here. As colon cancer generally develops slowly, a person can have cancer for many years without showing any symptoms. So the screening is aimed to detect and treat cancer before the onset of symptoms. In Quebec, specifically, screening for colorectal cancer in individuals at an average risk with or without symptoms factor screening is every 2 years. That's the recommendation from the Quebec government. And if you're of age 50 to 74, we consider you in that high risk population. So screening definitely is scheduled every 2 years. Individuals without symptoms, which we refer to in the medical world as asymptomatic, should be screened every 2 years using a fecal occult blood. And what that is testing for the presence of blood in your stool. It's a safe and painless take-home cancer screening test that you can do, and you bring it back, and it's assessed in the laboratory. Anyone who presents with an abnormal fecal occult blood test should be followed up with a colonoscopy. A colonoscopy, if we don't know, is a procedure that permits the examination of the large intestine to check whether or not there is a cancer or a polyps that is present. Regardless of the age, people need to have diagnostic workup should they present with any of the previous symptoms that I mentioned in the other slides. And also, if you know there is a family history, this is something that you should be doing regular screening in conjunction with clinical visits with your family doctor. When a cancer is suspected and a medical workup is organized, it's typically known as investigating for staging if there is a cancer. What does that look like? So a physical exam will be organized with your family doctor or with a doctor from the oncology surgical department. And that's a digital rectal exam. It's very simple, a little painful and uncomfortable, but it's done. That's first step. Blood work. Blood work, what does that also encompass? That encompasses biochemistry. So biochemistry is looking at the function of your other organs and how well they are functioning. Complete blood count. So checking for anemia, checking for your white blood cell count that's there. And also looking at a marker, which I'm sure some of you, if you are familiar with colorectal cancer already, known as the CEA or CA19-9. That's a really good prognostic marker that we use to help us detect whether there's an abnormal amount of cancer in the bloodstream. And we also use that marker that once we've determined there's a cancer and you started on treatment, we use it for routine follow-ups with your oncologist to see if the treatment prescribed is working. Treatment planning is extensive. It's not walking in to an office and saying you have cancer after you've gotten all of these tests done and this is the treatment we're giving you. It requires many people at the table to make a decision based on your family history, based on any comorbidities, meaning your overall history, based on the symptoms that are presenting and the location of the tumor that we've determined. So grading and staging is important terms to know, and they're important terms that you may have heard in discussion in a clinical visit. It's important to understand that they're not the same thing and they're very different. If you've heard of the term grade, the grade is a score of how fast the cancer is expected to grow and spread. How abnormal do the cancer cells look under a microscope? The higher the score, more likely the cancer will grow and spread quickly. A low-grade cancer is described as the cells are abnormal, but they are arranged and look like normal cells. A high-grade cancer, the cells are what we call poorly differentiated or undifferentiated. The cells don't look like normal cells and they are arranged very differently than normal cells. Staging is when you describe staging is what doctors use to describe the local, staging is what doctors use to determine whether or not your cancer is local, regional, or distant. What does all that mean? Local means that the cancer is only in the colon or the rectum and has not spread anywhere else, any other body parts. Regional means it's close to or around the colon or the rectum, and distant means it's in part of the body farther than the colon or the rectum. The most common staging system for colorectal cancer is the Tnm system, and there are 5 stages to this. As we can see from this diagram, this is the colorectal staging system. As I mentioned, the Tnm. T stands for the tumor and uses different numbers to explain the size of the tumor. N stands for the nodes and indicates whether the cancer is spread to the lymph nodes. And M means metastatic. Metastatic indicates that the cancer is spread to a distant organ outside the colon or the rectum. And here you can see, these are the early stages. Stages 1, 2, are 0 also, we would consider the early stages. Cancer cells are found only in the innermost lining of the colon and have not spread. Stage 1, the tumor has spread beyond the inner layer, but remains always in the colon. Stage 2, cancer has grown outside the colon, but has not spread to the lymph nodes. And cancer has grown outside the colon and has spread to the lymph nodes is known as stage 3. And stage 4, cancer is spread to other parts of the body. And as I mentioned, that is known as metastatic cancer. Sorry, I'm having a little technical difficulty with changing my slides. Here we go. Okay. Colon cancer is more than one disease. So if you recall in earlier slides, I mentioned there's a difference between left and right. There's a different presentation between young versus old. And now I'm going to introduce the term of molecular profiling. What is that? You may have heard of molecular testing, also known as biomarker testing. This allows us to know your genetic makeup. Tumor genes and testing give the physicians a pathway to uncover if there are potential targetable features of your disease. The results of biomarker testing will help refine your treatment. So for example, if you see, this is a very busy slide, but it's the best I could find to illustrate how valuable biomarker testing is. If we know you are having a specific biomarker, we can then target your disease in a specific way. If, for example, there's a clinical trial that we think you might be eligible for, doing biomarking testing will tell us whether or not this is a treatment option that is available for you. Biomarkers are divided into diagnostic, prognosis, predictive, and understudy or emerging biomarker testing. We do all this, but you say, what's the right care? What's the right treatment? Once we do all of these blood works, I've done imaging such as an MRI or a CT scan to find the location and see the size in relation to where the cancer is related. What's the right treatment? No two people are the same. So the idea is to give you a personalized treatment, and biomarking testing helps us deliver that personalized treatment. When is it the best time to do biomarker testing? Soon after a colorectal cancer diagnosis has been confirmed, before we start treatment. Because as I said earlier, it helps us define and fine tune what the treatment options are. In stages 2, 3, and 4, prognostic biomarkers such as the CEA marker help us to fine tune things. In stages 4, which is metastatic, we have other biomarkers known as KRAS, NRAS, BRAF, and HER2 that also help us with the treatment planning. A biomarker that you may have heard of in clinical visits is known as mismatch repair biomarker, or MSI. And this is a test that's for everybody. Mismatch repairs cells are the ones that fix the mutations in our DNA and helps us to make copies. If your mismatch repair isn't working properly, you'll have a buildup of errors in your DNA that become unstable. And this is called microsatellitic instability. We often see with biomarker testing, other options become available for our patient population to explore other treatment options with their oncologist. We often know that treatments will change. And I think that's one of the take-home messages that I want to also leave with you. Once you start on one treatment, if the treatment isn't working after, I don't know, for example, 2 cycles of a treatment, please don't give up and please don't have despair. We have a toolbox of resources, and it's our job as a committee, a multidisciplinary team, to go into that toolbox and look for other options to provide for you based off of all of your genetic profiling and your overall well-being as a person. It's not easy to always have the right fit at the right time, but through continuous research and through continuous testing, we get there. We don't give up. We don't want you to give up. Your multidisciplinary team. When I say we all sit around a table, and I've said this to many patients before, and they sometimes think they question me, but it's true. This representation is how many people sit around a table to come up with a treatment plan just for you. It's not just your oncologist's vision of what's best for you. He's one part of many voices around the table. So from a colorectal surgeon to a dietitian, to nurses like myself, to social workers. Even you say, why a social worker? Because we need to know the treatments that we ascribe to you, are they something that you can manage? And we need to anticipate pitfalls that may occur. So we have to have everything in place before we leave you with this one option. And this is why it's important to have a solid physician partner relationship where you can have open dialogue and exchange of information so that you feel secure knowing that this is the best plan and I will have support as I embark on this plan. Multidisciplinary teamwork is a concept that the Jewish General prides itself on for following. Professionals from various specialties, at times also from outside the organization of the Jewish General, we come together to deliver a comprehensive patient care plan to ensure the best health outcomes are met. As an IPO nurse like myself in the colorectal team, I'm proud to be an active member in the coordination of a patient's care to provide the delivery of their treatment. My collaborative efforts are often to ensure that the lines of communication remain open between patient, physician, between physicians sometimes, and also to address the complex needs that occur during a cancer trajectory, whether that be psychosocial needs, financial needs. It's my role to be the bridge between the resources within, the resources within the hospital and those outside the hospital to best support the patients through their journey. Treatment overview. Many treatments exist, but before the treatment starts, for me as a nurse, this topic is extremely important. And I know sometimes I'm not part of the discussion for various reasons, but if I can leave you with anything, if you are young, if family planning is on your mind, this slide illustrates the importance of starting a conversation. Before you start treatment, fertility preservation is an option that's offered to all patients before they undergo treatment, such as chemotherapy or radiation, to help patients, because we know treatment options can affect your fertility. Referrals are typically sent outside the Jewish hospital to the Montreal MUHC Reproductive Center, where we send our clientele, both female and female, for counseling on fertility-related risks and treatment options for fertility preservation. This slide, I've only mentioned a couple. I don't know too much in detail, and this is why we refer to the experts outside of our institution. But the ones that I do know of, and I know patients have undergone these and had good results, are, for example, egg freezing. So that's unfertilized eggs can be removed and frozen for later use. Ovarian tissue banking, which is removing part or all of an ovary and freezing the part that contains the eggs, again, for a later use. Sperm banking, as I mentioned, we don't just cater to females, they cater for males because everybody has that right to discuss this issue, as this may be something very important to you. And medications to help preserve your ovaries, for example, might be another option as a fertility treatment. Fertility options often depend on the stage of your cancer, the type of your cancer, the age of the patient, and what the cancer treatments will be. It's important to you, have the discussion. It's something that needs to be outlined before treatment is started. So treatment is started. Let's recap. We had symptoms. We went to a family doctor. Family doctor did some testing, said, here's the occult test. That came back positive. Oh, I'm going for a colonoscopy. I go to a colonoscopy. Oh, we saw something, but we're not sure what we saw. There was a polyps. Let's take a tissue sample of that and send it to a pathologist for further investigation. We've come back. We've confirmed the cancer diagnosis. What now? So these are the different views of treatments that are available. All of these do not apply to everybody for various reasons. For example, surgery. It's a removal of part of the colon where the cancer is located, and nearby lymph nodes are also removed at that time. But having a colorectal surgery depends on the patient's age, their performance status. Are they functioning well? Or is this a healthy 60-year-old, or is this a 60-year-old with many illnesses that we don't know if surgery is the best option right now? The location of the tumor. Is it something that we can easily get to right away? The molecular profile of the tumor. All of these things are taken into consideration before we take that approach. Radiation. Radiation is the use of high energy rays to kill cancer cells, but there's several ways that can be done. It can be done by external beam radiation or stereotactic body radiation. This is also used sometimes, radiation, to control symptoms of pain, blockage, intestinal blockage, or bleeding. Sometimes these things are used in combination, these treatment overviews. So many times we've seen where, example, before surgery, we would actually use chemotherapy to help shrink the size of the tumor, to help removal of the tumor, making the tumor smaller. It would be easier to be removed. We've also seen chemotherapy being used after surgery to help the cancer that was removed, to make sure that we've caught everything. So we want to give some chemotherapy to ensure that we kill all the cancer cells that have been left behind, that are microscopic, that we cannot see. During surgery, if that's the right choice or course that your physician finds, sometimes we also give chemotherapy intraoperatively, and that's to kill the cancer cells directly right at the area where everything has been removed, and again, to make sure that we haven't left anything behind. And as I said, radiation is something that can be used not only just to kill the cancer cells on the spot, but can be used for symptom management, chronic pain, bleeding, to cauterize an area, or even just for intestinal blockage to help manage symptom control, as we would say. Both surgery and radiation are treatments that we refer to as local treatments, as they target the tumor without trying to affect the rest of the body. Systemic therapy includes chemotherapy, targeted therapy, and immunotherapy. Chemotherapy, I think it's a term that everybody is familiar with. Chemotherapy can be given intravenously by IV, so you come into the oncology center at the Jewish, or it can be given orally through pills that you will manage at home. Those are a bit more tricky because patients sometimes feel a bit abandoned when they're on oral therapies, that they don't have a check-in. They don't know what's normal from not. I encourage if you know any patients or family members that are receiving oral chemotherapy, signal the bell that they should be connected to an IPO nurse like myself, because we can help manage those symptoms at a distance. I don't want anybody to ever feel that they're alone with coping with what's happening in an environment outside the hospital. There's always resources to help support you. targeted therapy and immunotherapy are, unlike chemotherapy, they're effective at treating cancers with specific features. So this is where the biomarkers come in. Targeted therapies can target and attack specific receptors that are found in the cancer cells from the biomarking testing. So this is why biomarkers that we were mentioned earlier is very important to do early on, so we know part of which treatment works best. Emerging therapies, those are clinical trials. Clinical trials are, they're basically, it's research. It's ongoing research that we think is promising, but we're not quite sure. So if your physician, your oncologist believes you are a candidate based on your molecular profiling, your performance status, how well you're functioning, and past treatments or new treatments that are coming out, they might suggest a clinical trial. Some patients are resistant to the clinical trial because it's a novel therapy. I understand, but I think, and I encourage all my patients at any time to keep an open mind. We never know what's on the horizon. Clinical research is hope, and it's hope in a way that it helps guide us for future treatments and ways to target and really help decrease the rates of colorectal cancer. So if you see a flyer in the hospital, if your oncologist sits down and says, you know what, there's a clinical trial coming about, we think you might be a good candidate, please sit with an open ear, listen. A lot of information will be presented, write your questions down, and then come back if you have more questions. Don't be shy. You need to make an informed decision, but I want you to make a decision with all the information on hand, because we were trying to give you the best options possible. Supportive palliative care. Personally, I don't like the term palliative care because it sounds so final, and that's it. Supportive care for me is a more of appropriate word. And the supportive care team at the Jewish General is phenomenal. Supportive care, their main goal is to improve your quality of life for you and your family members. It's a form of care that should be introduced at the onset of your diagnosis, and it can work in conjunction alongside with curative treatment. So if you remember back a few slides ago, I said pain management. Sometimes radiation, supportive care will say, after radiation, you've got pain, but we're not sure how to manage this. Supportive care, they have a wheelhouse of expertise with regards to medication. And maybe they could find a medication cocktail that's perfect for you to help manage that pain while being able to have the lifestyle that you would like to have and not be bedridden, not be sick. They are a global team that doesn't just look at cancer, but they look at the patient and the patient's desires and their goals of treatment, which is extremely important. This is an example of surgeries. I didn't want to get too specific because there's many, many types of surgeries, but the take-home message here is the difference between a surgery like a colectomy and the difference between a colostomy. What's a colostomy? We'll get to in the second picture, but a colectomy is a surgery that involves removing the cancerous part of the colon. And then the two healthy ends that are remaining are attached, and any nearby lymph nodes are also removed at the time of surgery and sent for testing. Side effects of a colectomy, excuse me, can have a change in your bowel habits. That could be like the frequency of your bowel movements, the urgency to go. This is typically what patients will report post a colectomy surgery. A colostomy is when you take two healthy ends, but they can't be reconnected post-surgery. So this is the part where we connect them, the healthy end outside the body through the abdomen, and we create an opening that allows for the stool to pass through. At the Jewish General, we have a clinic, the ostomy clinic or the insteratoma clinic, which is comprised of 3 nurses excellent in their field, and they provide teaching post-surgery at the bedside on management and even ongoing. If you have problems with the appliance, how to care for it, the skin around it, the integrity, there's different fits for different people, not one bag, i.e. a colostomy is the right one for everybody. And their job, because they have the expertise in this field, is to help guide you to find something that works best for you. Chemotherapy agents, there are many, and I won't go through the types. I just wanted to show you a quick visual of the main go-tos with colorectal cancer. All of these have side effects, and the side effects will depend on the drug used, the dosage, and length of the treatment that you're taking. What's important to know, you get teaching. There's ongoing teaching. At the time that a decision is made on the treatment agent, your oncologist will tell you possible side effects. After that, you will have a conversation with the oncology pharmacy team, who will again go through possible side effects, foods to avoid. They will review if you are taking any other medications that might interfere with your chemotherapy treatment to ensure your safety. Another pit stop of teaching is in the chemotherapy treatment center on the 8th floor at the Jewish. Those nurses in the oncology center, I cannot rave so much about them and their extensive knowledge of these medications. They know far more than I do because they give it daily and they see it daily. So that's another level of teaching that's provided. There are a few options of giving chemotherapy. There's in the neoadjuvant stage, which is administering chemotherapy before a main treatment. So as I mentioned earlier, prior to having surgery, we might give chemotherapy to help shrink the size of the tumor to help make it more resectable. And there's chemotherapy in the adjuvant setting, and that's treatment given in addition to the primary or initial therapy to maximize the effect of the treatments that we've provided. Sometimes treatment is given in the palliative care setting, and that's just to help with management maybe of pain, or again, the size of the tumor to help with shrinking it. Chemotherapy is not, chemotherapy has become part of our everyday landscape that we've been seeing, and patients go on to live active, healthy lives. I will not sit here and say you will not have side effects, because you possibly will. What's important to know is that if you do have these side effects, guidelines are given to you continuously on how to manage those side effects. Reach out. If you are sitting with side effects, I can't stress more, please don't sit idly by and hope that they will go away. Speak up and help will be given to help guide them. Even if it's with your oncologist, because sometimes if the side effects are unbearable, and that's not what we're looking for, he or she will review whether or not this is the best treatment option for you. So it's important to have that open line of communication with your oncologist, with your nurses at the time that you're receiving chemotherapy. In the metastatic stage, meaning colorectal cancer has spread outside the colon or the rectum, it's important to know that there's an algorithm. Your physician, your oncologist does not just sit there and say, this is what I'm going to give, this is the only option. Again, a lot of information, but what I want you to know is that there's an algorithm that has been designed, we all follow it worldwide, about what are our best options. On the side here, you'll see 1L, 2L, and 3L. This refers to line of treatment, first line of treatment, second line of treatment, and your third line of treatment. For example, if you do a biomarker testing and you see that you have a BRAF mutation, We know in the first line setting, your first line of treatment, given you have a good performance status, comorbidities are limited and manageable, FOLFIRINOX may be the best option that your oncologist will prescribe. Excuse me. So keep in mind, as I said, we keep going through all of our lines that are available given your molecular profile in this algorithm that has been publicly and researched, reviewed, so that we know we are giving you the best treatment options. Clinical trials, research is hope. So again, keep an open mind, keep an active ear, take notes. If it's too much information, come back to the nurse like myself, ask questions. We'll fill in the blanks, we'll make it clear, but we want to keep your options open. So research is continuously going on. They give people access to investigational treatments that are available when conventional treatments are no longer working or the side effects are unmanageable. Survivorship. Cancer journey is long, and after you've experienced treatment of colorectal cancer or treatment for rectal cancer, sometimes, now we're living cancer-free. Yay! Survivorship focuses on the health and the physical and psychological and sometimes even economical issues affecting people at the end of treatment. The disease changes your life in a number of ways, and side effects are sometimes immediate and long-term physical side effects, and ongoing screening and monitoring needs to continue. The post-treatment period is what we call survivorship. And while survivorship varies from patient to patient, there are common concerns that often affect cancer survivors. Surveillance. Surveillance is important, and that's to manage and monitor in the next 5-year period chances of reoccurrence. So surveillance is something that's negotiated and scheduled by your oncologist and your treating team to make sure that you have regular physical follow-ups, typically a physical exam every 3 to 6 months, and that blood works, tumor markers are all monitored. Side effects are also explored, and to make sure that issues of side effects like fatigue or constipation or diarrhea are also well managed. Again, going back to the quality of life. Managing emotional side effects is also very important. Anxiety about the future, returning to work, finances, those are real stressors, and we want to make sure that we address those and provide you with the available resources and support that you need during that time. Palliative care, as I mentioned, I call it supportive care. It's an important part of your trajectory, and it's an important part of knowing that there is a team that just focuses on controlling your symptoms. And I strongly urge that palliative care be discussed openly in the beginning so that your quality of life, or the quality of life that you seek to maintain, is explored and ways of maintaining that quality of life are addressed. For me, this is my take-home message for everybody. Health is increasingly being recognized as a balance of many factors: healthy eating, exercise, emotional stressors. And the role of cancer, or your mind causing cancer or any type of disease, has been debated for many years. My role as an IPO nurse, I've found, however diverse the patient population, economically or ethnic or cultural background, even educational level, they all go through the same similar process. After the initial period of devastating news, they assess their situation and then they accept their new normal. So sharing with others how you feel and receiving aid or support from friends and families on how to fight and how to continue is important. Please remember to be kind to yourself and know that there are many resources around you to help support you. My goal with each patient encounter is to remind you to live in the present, not the past, to help you set realistic goals and be willing to compromise sometimes how we meet those goals as you're presented with a new normal, and to help you regain a sense of control over yourself and a sense of independence and increase that self-esteem. Again, cancer is a period of uncertainty, moments of worry and stress, but there is available help, as I call my toolbox of resources that you can go to help guide you in those moments. It is clear that much research needs to continue, as it is continuing with colorectal cancer, but it's an area that I'm very passionate about and very hopeful for the future as new research is emerging. So I thank you again, and that would end my presentation. I don't know if there's any questions.
Thank you so much, Natalie. Throughout the presentation, there were no questions entered in the chat, which is great because I think that was a super comprehensive presentation. I know I learned a lot, which is always the goal of these presentations. If anyone does have any questions that kind of arise in the next little bit, we always encourage you to refer back to your oncologist, your IPO, whether that's Natalie, whether it's someone at whichever hospital. So that's it for now. Once again, Natalie, thank you so much for your time and for this very detailed but also simplified presentation. The conference has been recorded, so if you want to see it again, give us a few days to get it up on our YouTube channel. And we just wanted to remind you that on April 7th, so next Thursday, we will be holding a webinar, Cancer in Your Teeth. We hope you'll attend again. We thank you for everyone for showing up today and for participating. And we wish you all a wonderful afternoon. So thank you so much, everybody.
Thank you.